Dr. Anthony Fauci has received nearly every honor American medicine has to offer, and he'll tell you almost none of it is the point. It started with his family pharmacy in Brooklyn, where he learned what an important role healthcare providers play in the community.
My father, he was the neighborhood physician for people who couldn't afford to go to physicians. So his entire mantra was service. So I got that instilled in me as a youngster, that service was really, really important.
As a young scientist, he helped turn an autoimmune disease with severe mortality into one where most patients now enjoy remission. He was part of the movement that turned HIV into a disease managed with a once-a-day therapy. Together with George W. Bush, he created PEPFAR, a program that has saved more than 25 million lives. In our interview, he shares his experiences working with 7 American presidents.
I mean, real outright humor, jokester was George W. Bush. He's the biggest jokester of them all.
Right.
But the subtle humors is Barack Obama.
And at 85 years old, after a lifetime of achievement, we just had to ask, what gets you up in the morning?
My wife.
Please join me in thanking the legend, the man, Tony Fauci. Welcome to Stanford Department of Medicine's Inside Look at the Future of Medicine. Well, Tony, what a pleasure it is to welcome you to Stanford. I wanted to say, first of all, is it okay if I call you Tony?
Of course.
Yeah. You mentioned, you've been in my ears the last few days because you wrote this amazing book, On Call, that talks about your own story. And I like to listen to audiobooks, which is how I ingest my books. You mentioned in the book that only 2 people actually ever called you Anthony. And one was the discipline master at your Jesuit school, and the other was Donald Trump.
No,
Jr.
actually, it was different. Everybody was calling me Anthony when I was a child. I went to Regis High School, which is a Jesuit school in Manhattan, and they had, believe it or not, they had the dean of admissions, the dean of studies. They had a dean of discipline in a Jesuit school. And I remember the first day, everybody would call me Anthony. We were being introduced to the dean of discipline, and everybody was afraid of the dean of discipline. And someone would go over and say, what's your name? He'd say, my name is Francis. Such as, oh, Frank, welcome to Regis. And then they would go to, guy's name is James. He said, oh, hey, Jim, welcome to Regis. He says, my name is Anthony. He says, well, Tony, welcome to Regis. I was so frightened. Ever since then, I was Tony. That's how I got Tony.
The dean of discipline made it so. Yeah. Until this one president also apparently, on occasion, would use your full name.
When he was angry, right?
Yeah. And I'm sure we'll get to that. Well, as you heard already, As you heard already in the intro, you grew up above your father's pharmacy in Bensonhurst.
Right.
Brooklyn boy, baseball fan, big Yogi Berra fan. Talk to us, first of all, about those origins. You've had this incredible, long and storied career. We'll come to talk about so many of your achievements in the next half hour or so. How were those things, a picture of Fauci Pharmacy right behind us? Tell us how those formative years really impacted and led you to where you eventually went.
Well, they definitely did, but I get asked that question, a fair amount. Yeah. And the one thing that's apparent to me is that it had a major impact on me, but it was probably beneath my level of consciousness that it was having an influence on you, because when childhood experiences and youth experiences influence you, you don't psychoanalyze yourself when you're 8, 9, 10 years old. But my father and mother, as you mentioned, ran a mom and pop pharmacy, and this is the 1940s and 1950s. So I was born in 1940. I know I'm not going to faint under the thing. I'm pretty old. But I was, 7, 8, 9, 10 years old, working in the pharmacy, delivering. The thing about that atmosphere was that it was really the neighborhood service center for helping people. It was truly neighborhood service, unlike the industrial pharmacies of today, which are fine, Walgreens and CVS and others, that it was more of a business. So not only was he filling prescriptions, but he was the neighborhood marriage counselor, he was the neighborhood psychiatrist, he was the neighborhood physician for people who couldn't afford to go to physicians. So his entire mantra was service. So I got that instilled in me as a youngster, that service was really, really important. It was sort of ingrained in me and kind of in my DNA. That was very much fortified by what you mentioned, Euan, going to a Jesuit high school and then ultimately a Jesuit college, because the theme of a Jesuit education is, well, it was an all-boys school at the time, so it was men for others. It should be people for others, but it's men for others. And that was, I think, started off way back then, which I think is the motivating force of why I went into medicine. I had a circuitous route in medicine because I took mostly a classical Greek, Latin, French, and with just enough science to get me into medical school. So it was more of a humanistic approach as opposed to a scientific approach. And only when I got into my fellowship did I really get deep into the science.
Well, and who knew at that time, you certainly didn't, that you would lean on all those learnings in many occasions through the following decades.
Yeah.
When did you first become interested in science then, if you had this humanistic early education?
You know, I was struggling with, as all young people do, with what I wanted to do. I was very interested in people and very interested in doing things for people. I think the classic education was really important in fashioning me to be the kind of physician, scientist I ultimately became. So I was very fascinated with the history of civilization. That's why, Greek was very exciting to me, Latin and ancient history, et cetera. But when I got into high school, I really liked the sciences. So I was trying to figure out what the best way to combine. I didn't know I was any good at it yet because, you're just taking courses in school. So, you like it, you get good marks, but you're not sure if that's something you really want. Yeah. So I was trying to figure out what the best way to fashion a career, at least as linear as I could get. So that when I went to Holy Cross College, which was interesting because the course at Holy Cross was almost oxymoronic in its title. I had a Bachelor of Arts, Classics / Philosophy class pre-med, which is, like, what?
You may be the only person in history with that.
And what it did is that it really was much more, at least in my own mind, emphasizing the patient and the person as much or more as the science associated. So I went to Cornell Medical School, New York Hospital Cornell Medical Center, now Weill Cornell, and I literally had just enough science in college to get into medical school. I did, and then only after that did I amplify on the scientific. But to me, it was the right balance between my very strong propensity to want to be with people and do things for people, and science as a vehicle to do that, as opposed to, and there's nothing wrong with the opposite. I think it's great. This would be to be fundamentally a core scientist who maybe not want to do it with people. So it was sort of the other way around.
And you had this moment where I think you either had an option of a chief residency or potentially to go to the NIH.
No, actually, it was a little bit different. You got the right setting. Yeah. I finished a few years of residency after medical school, and I wanted to do a fellowship. And I was talking to some of the Stanford students just a little while ago about the lack of linearity in career, because when I graduated medical school, did my residency, I wanted to subspecialize in the joint. I took a joint fellowship in infectious diseases and clinical immunology with the full intention of going back to Cornell, becoming chief resident, and being on the staff, clinical staff at the New York Hospital Cornell Medical Center. I was so differentiated, as I joke around, but it's true. Not only did I want to go back to New York Hospital and practice medicine, I wanted to have my office on 71st Street and First Avenue. So I knew exactly what I wanted to do. So talk about the lack of linearity, but something happened on the way to the forum. I fell in love with science during my fellowship, and I had a very good mentor. I got on a good project, and it was really quite successful. So I was left with a decision because I had already committed to be chief resident in medicine back at Cornell. And my mentor, and that's to all the students in the audience, find yourself a generous mentor. It's really important. He said, you're uncertain what you want to do. I'll make a deal with you. Go back to Cornell, be chief resident of medicine. If you decide you want to stay there and just practice medicine, we'll be friends forever. If you decide you want to come back, I have a tenured position for you at the NIH.
Yeah.
So I went, I had a phenomenal year. Back then it was every other night and every other weekend. So I just was awash in clinical medicine. I really loved it. But I made the decision I wanted to go back to the NIH, and I did, and I was there for the subsequent 54 years.
You've been there for a few years now. Yeah. I think that many of us who know you in more recent times as a very public figure and someone who administers obviously an important institute and has led many international groups, maybe we forget that your career as a scientist, you were for 20 years among I think, and still are, among the world's most cited researchers. So the early work from your lab was already making an impact. Tell us a bit about vasculitis and in fact, share something that we should know that you published from your lab that we don't.
Well, it gets back to circumstances impact the lack of linearity of career. So in my fellowship, I got put on a project to study a disease which used to be called Wegener's granulomatosis. It's now granulomatosis with polyangiitis. It's uncommon, not rare, deadly disease, 100% fatality, particularly if you get renal disease. My generous mentor said, we have to figure out a way to do something. This is a completely fatal disease. So I was also getting my boards in infectious diseases. So at the same time as I was interested in the autoimmune aspects of this disease, I was clinically an ID doc.
Right.
So we would get called up to the Cancer Institute and the clinical center at the NIH is on, the old clinical center was on the 11th floor, the Cancer Institute was on the 13th floor. So they were giving people chemotherapy because they were developing at the time, this is 1968, 69, 70, 71, what turned out to be the cures for acute lymphoblastic leukemia and Hodgkin's disease. And they were putting them on BLAST, CMOP, CCAP, all of those diseases, which included high-dose cyclophosphamide. So we got the idea that steroids was not working in GPA. Again, it was called Wegener's then. So we decided, why not try a low dose of Cytoxan that you could titrate instead of a gram per IV push, give them like 1 to 2 milligrams per kilogram per day, and titrate so you never let the absolute neutrophil count get below a certain level. Mm-hmm. So we avoided all the infections of cancer chemotherapy, but luckily it was just enough immunosuppression to completely shut off the disease. So it went from 100% mortality to our first papers in the journal Medicine and in back the old journal Medicine and in New England Journal of Medicine was a 93% remission rate, which was like blew apart the whole field of autoimmunity where you could actually give a cytotoxic drug. So I became at a very, very young age quite well known in immunological, rheumatological circles. Remember, I said I came back to be chief resident in 1972. And from 72, 3, 4, 5, 6, 7, we made it better and better. The disease, the therapy has been somewhat replaced now with rituximab, which, if it isn't very serious, I would still use cyclophosphamide for overwhelming disease and consolidate with rituximab. But before, we just use cyclophosphamide. And that was going great. And I was on a real accelerated curve going on to, or getting into all the right societies and things. Then in 1981, everything changed for me because I got the first reports of this unusual, it was one report from MMWR. I was sitting in my office on the clinical center in June of 1981, and I got a MMWR with 5 cases of pneumocystis pneumonia from Los Angeles, curiously all in young gay men. I said, what is going on? I thought it was, at the time, young men were taking poppers to enhance sexual satisfaction. I thought maybe that was immunosuppressing them, but poppers shouldn't be immunosuppressing them. So I just put it aside, didn't think about it. 1 month later, in July of 1981, the second MMWR came out. This time, 26, amazingly, all young gay men who were previously healthy, not only with pneumocystis, but with other OIs and with Kaposi sarcoma. So I did something that my wise mentor who helped me in my early career, I said, I'm going to totally change the direction of my career. I'm going to take all of these protocols that we've developed that by that time had gotten into the textbooks. I'm going to give it to my trainees who are now senior investigators, because 10 years had gone by, and I'm going to devote all of my time clinically and in investigation on HIV from the summer of 1981, which was one of the first 2 or 3 people involved with HIV. And that was before it had a name. It was called GRID. And it didn't have an etiologic agent until 1983 with Luc Montagnier, who discovered it, and Bob Gallo proved it in 84. So I went for 2 to 3 years taking care of a deadly disease with no name until 1982, where all of my patients died. So I had this incredible shift of becoming this hero who was saving people with a deadly autoimmune disease with a therapy I developed, to all of a sudden, all of my patients, with very few exceptions, were dying.
Yeah.
So that was a really interesting transition, which started the 45-year journey that I've had with HIV, from no treatment to 1 pill a day, and you get rid of everything.
An incredibly bold change for a young, at the time, investigator to really, and it sounds like your mentor had advised you otherwise.
Well, he told me, he said his words were, "Don't give up your day job."
Yeah. Seemed fair. Turns out not to be. For the first time, you were probably right about what you saw coming. One of the things that struck me in listening to your book is just the extent to which you really have been the ultimate physician scientist. So when you eventually, sometime after that, got offered the job as director of NIAID, you said there were 2 non-negotiable things, clinical medicine and science, that you would run the institute and do it well, but you didn't want to give up seeing patients, and you didn't want to give up your lab, as well as the 1,300 papers or whatever the current number is, and all the citations starting from when you just mentioned. You've also been, as many in the audience know, an editor for, I think, 36 years of Harrison's Principles of Internal Medicine.
41 years.
41 years. yeah. Okay, I didn't count that quite right. So, but pretty good. 41 years. This is just one of them right here. See, sorry, 41 years, 35 plus 6. So, and for many of those in the audience, this is how they first heard your name. Talk about being a physician scientist and what that really means to you, and then let's go back to those dark days in the early days of.
It depends on what you decide. Well, you don't really decide because it happens. What your identity is. So my primary identity is as a physician. My supplemental identity is as a physician scientist who is doing studies to have an amplifying effect on what you know clinically. In 1984, I had been working on HIV, and I started to work on. It was sort of interesting. We were working out the pathogenic mechanisms of the disease before we knew what the etiology is. So my first 2 or 3 papers in the New England Journal were describing things that I didn't even know what it meant, because we didn't know what the agent was. And the first paper that we did in the New England Journal in 1982-83 was looking at aberrant immune activation, paradoxically, in a disease characterized by immune suppression. So how does that happen? How do you get paradoxical immune activation? As it turns out, the immune activation that's triggered by the virus is the driving force for virus replication. So now everybody knows you put the virus in culture and you activate it and the virus just spreads. So I didn't even know it then. So I loved that. I didn't want to change it. But one thing was happening is that we were not putting enough resources into HIV, or I thought even in the field of infectious diseases. When I became director, we were like the 7th out of 12 institutes the budget when I became director was $320 million of NIAID. When I left after being director for almost 40 years, it was $6.3 billion. Yeah. I didn't even get a parachute bonus for leave.
I know.
You know,
how does that work out?
It didn't work out. Work out. Yeah. But when I became director, apropos of your question, I absolutely did not want to leave my identity as a physician scientist. Up to that point, no institute directors, this is 1984 now, had their own lab or saw patients. They were just in Building 31 and were administering. So I made a deal with the director of NIH at the time and with the secretary of HHS, Jim Weingarten. Most people don't remember Jim Weingarten. He was a really distinguished physician, used to be chairman of medicine at Duke. I said, he wanted me very much to get the job, even though I was the youngest person ever to be an institute director. And I said, but my condition is I have to continue to see patients and I'm going to keep my lab, because I was the lab chief at the time. And he said, you know, I've heard about you. I don't know you well. I trust you. As long as you remember that your primary responsibility is to direct the institute and your responsibility to grantees out on the outside. And I gave him my promise that I would do all three and I would do it well. And he said, fine, I trust you. And that was the first time an institute director ever also had a lab. I felt that if I gave that up, I would be giving up my identity, and I didn't want to do that.
Yeah, I think that's a really good thing for all of us in the audience to hear. I think many of us feel that way. But to be able to say that to the head of the NIH as they're offering you a job is a whole other thing. But
you know, he could have said no, and then I wouldn't have taken the job.
Yeah. But I think that this idea of talking truth to power is something we'll come back to.
Okay.
Because I think your own truth there and your own identity, you know, is a really important part of I think that answer. Take us back to those pretty dark days before there were treatments for HIV, because you were looking after those patients.
Yeah. It was extraordinary, and you know, I describe it in the book. It was a very unusual experience that is very unique in medicine, particularly in the very early years when you didn't know what the etiology was, where, you know, the only thing you're doing is putting Band-Aids on hemorrhages, you know, and we didn't have any drugs, so you treat somebody's, you know, pneumocystis, and that goes away, and then they get CMV retinitis and treat that, and then you get cryptococcal meningitis and you treat that, and then sooner or later they all die, either that or with Kaposi's sarcoma. That was traumatic, you know, and I refer to it in the memoir, is really a post-traumatic stress that you still have.
Yeah.
What it also does, two things: the bravery and the incredible character of the patients you're taking care of is very inspirational. But the other thing that is really retrospectively, the motivation and energy you get about doing something for it is really profound. And that was one of the reasons why I decided to take the job as director. I mean, if you would have asked Tony Fauci in 1981, 2, 3, would you want to be a science administrator? I would tell you, you're absolutely crazy. There's no way I want to do that.
Yeah.
I don't mean to be.
No, all good, all good.
So I did it because I felt that we really, really needed to do something about that. So when I became director during those early dark years, it was, remember, we didn't get the first drug until 1987. AZT was approved. The second drug was 2.5 years later, DDI and DEC. And then 3 or 4 years later, lamivudine. It wasn't until 1996 that we had triple combination that actually brought the level of virus to below detectable and durably kept it there. So during that period of time, it was a combination of trying to not have despair, working your butt off administratively and scientifically to try and develop drugs, and then all of a sudden seeing this ray of hope go from absolutely nothing to becoming an outpatient disease that in a proper healthcare setting, which, you know, we can get into a discussion, which we don't have time for, of healthcare delivery in this country, no one should ever get sick from HIV. Because if you treat someone, you know, soon enough before their immune system tanks, you can get them, the actuarial curves show that you can leave essentially a normal lifespan minus maybe 1 or 2 years from the normal, all other things being equal. So the contrast from seeing patients in the 80s where it was totally frustrating to now, essentially just seeing patients on follow-up visits, checking things every
Remarkable.
It's just extraordinary.
Yeah. One of my favorite stories in your book, we have a slide to go with this too, is it ends with the line, Dad, it's Bono at the door. And I wondered if you wanted to share that story.
Yeah. Well, the Bono story is really related intimately to the PEPFAR story.
Yeah.
So let me give a brief
tell us about PEPFAR.
Discussion about PEPFAR, and then Bono goes in. From 1996 to the year 2000 or so, we were, essentially progressively in the developed world, USA, Australia, Canada, UK, European Union, we had available drugs and accessible drugs. So all of a sudden, the larger follow-up studies were showing the curves of people essentially leading normal lives. However, in Africa, where 67% of all the infections occurred, there were no availability of drugs. So I have, and still do, a lot of friends and colleagues in sub-Saharan Africa. So I would visit there, and it would be like a strange deja vu where I would be making rounds in Malago Hospital in Uganda or in South Africa, and my African colleagues were essentially a brown version of Tony Fauci in Bethesda in 1981, where all of their patients were dying because they were doing what I was doing. They were putting Band-Aids on hemorrhages. They couldn't even afford treating people for OIs, much less for that. So I became agitated or energized that we really needed to do something about sub-Saharan Africa. So I started to talk about that in my talks. I would, become almost a policy talk as opposed to a scientific talk. Fortunately for the world and Africa, George W. Bush felt the same way. So he called me in his office in the spring of 2002. And in his exact words, as I saw in the book, because I wrote it down, when the president tells you something, you don't want to forget it, so you write it down. Yeah. Well, some presidents. So he said, I believe, I being George Bush, that we as a wealthy nation have a moral responsibility to not allow people to suffer and die from a preventable and treatable disease merely because of where they happen to have been born and lived. So what I want you to do is go back to Africa and see if it's feasible and accountable to do something transforming in Africa. Meanwhile, Bono was also agitating for people to be doing things in Africa, and he was drumming up a lot of support, with the UN and with WHO. I went to Africa, and I looked around, and I hooked up with some Africans who were using philanthropically donated drugs to give to people, because the thought in the United States was Africans will never be able to take drugs, and they may not even respond to the drugs the way we do in the developed world, which is, holy mackerel, what a racist comment that is. But that's really what people were saying. So make a long story short, I got very convinced that we could do that. So I came back to the White House, and they said, we can do it. He says, okay, put together a program, but make sure it's accountable and it's transformative. He says, but one condition, you can't tell anybody that what you're doing. It's the truth. He says, because if the Congress and other people find out about it, they're going to want to put I want to do it the right way. So literally, I was doing this for 8 months, working with the White House staff, putting together this version, 15 countries, 12 countries, 10 countries, how much on condoms, how much on this, how much on drugs, how much on prevention. And somehow or other, I didn't tell anybody. And it was really very stressful. He says, you can't tell the secretary of HHS and you can't tell the director of NIH, you can tell nobody. So I said, well, you're the president of the United States. If you tell me I can't tell anybody, I'm not going to tell anybody. But somehow or other, in all things, something leaked out that I was working on something. So apropos of your question, sorry for the long introduction.
No. That was the intent.
But I get a phone call from Bobby Shriver, who is Sergeant Shriver's son, the guy who just developed Peace Corps. He calls me up. He says, I'm in Chicago with Bono and his team. He's doing a concert there. We would really like to talk to you about HIV in the developing world. I says, fine, anytime you're in Washington, I'd be happy to chat with you. He says, well, how about tonight? He says, we have our plane, we'll fly in, so maybe we could meet at some restaurant. And I said, we shouldn't meet at a restaurant. We'll never get a chance to talk. Everybody will see, nobody knew who I was. Everybody will see Bono when they all get excited. He says, no, but can we come to your house? So my wife, Christine, who's sitting in the audience, said, well, why don't you invite him on over? We'll cook an Italian meal for him. So
no pressure.
No pressure. So he flew in, he came in, he stopped off at a wine store, bought some wine, and I decided I was going to play a joke on
What kind of wine does Bono bring today?
More than I could afford.
Yeah.
So I decided to play a little trick on my daughters who were in the young teenager and lower. I knew he was going to come to the door, so I told my eldest daughter, Jen, I said, I'm going to have some people coming over from the lab tonight. So when the doorbell rings, let them in because I'm going to be inside the kitchen with Mom. So the doorbell rings and she goes to the door. She opens the door. All of a sudden I hear a scream. And she says, Dad, Bono's at the door. I said, well, let him in. So we had a phenomenal conversation, which was interesting, is that I told Bono that I am working on something, but I really can't tell you what it is. So he, in his enormous, what an amazing guy, generosity, said, okay, tell me how I can help. And I said, when it happens, we need your support. Because since George W. Bush was a conservative Republican, we were concerned that the people who were kind of, leaning away from his ideology would not be in favor of it. He said, you got to gather support because once we get it done, we're going to need congressional support to get it authorized and appropriated. And that's what Bush, his genius of this, he kept it quiet literally until the night before the State of the Union address on January 28th, 2003. And he called me and Mike Gerson. Some of you know Mike Gerson was his speechwriter. He brought us down to the White House, and we got the day before, literally the evening before, we got on the phone calling up every major person in the Congress who we needed support, saying, by the way, you're going to have a surprise tomorrow at the State of the Union address, just to let them know so they wouldn't be upset. And he made the announcement on January 28th, and then bingo, that's what it was, for $15 billion for 5 years.
Just remarkable. And it's estimated, and you're correcting my numbers through our conversation today. So tell me if this is correct. 25 million lives saved?
Yeah. So it started off, my proposal was... My proposal was $15 billion over 5 years to aim at treating 2 million people, preventing 7 million infections, and taking care of 10 million people, including AIDS orphans, which is what he accepted. You fast forward, 23 years from then, it now is over $100 billion, $110 billion. It's in 50 countries. And it has saved 26 million lives, which makes it the most successful life-saving public health program for a single disease in history. Now, having said that, it really shows you, quite frankly, I don't mean this in a facetious way, what presidential leadership can do. And he made me the vehicle for it, but it would never have happened if it wasn't for George W. Bush.
Well, that is actually my next question, because you, and correct me here again, have worked with 7 different presidents, 7 administrations. That gives you a really unique insight into that office. What can you tell us that we don't know?
Yeah, well, Well, again, as I described in the memoir, it really relates back to the first time I was called to talk to Ronald Reagan in the mid-1980s. And as I was getting ready, I told her the story. Ronald Reagan did not, mention until the second year of his second term, and he, I think, lost the opportunity to use the bully pulpit of the presidency to call attention to the things that we needed to do. Even though fundamentally I thought he was a good president, but he missed that opportunity. So I wanted to talk to him about that. As I was getting ready to prepare, I called up a friend of mine who had spent 6 years in the Nixon White House, a very wise guy named Jim Dixon. And he told me, he says, let me give you a word of advice. He said, this is the first time you're going into the White House. Whenever you go into the White House and you're getting ready to go under the awning of the lower level of the West Wing, which ends into the White House, he says, whisper into your own ear that this may be the last time I'm going to come into this building, because I may have to tell the president an inconvenient truth that he might not like. I might be the messenger that gets shot, and I might not get asked back again. And then you may say, well, what's the mean about it getting asked back? Let me tell you not a secret about the White House. I've been to the White House now hundreds and hundreds and hundreds of times over the last years. Anytime you went to the White House, you have a feeling of awe. You walk in and like Lincoln was here, and Franklin Delano Roosevelt was here, and Harry Truman was here, and Eisenhower was there. So you have an instinctual, understandable, but dangerous feeling of you needed to get asked back. and you might subconsciously, without even knowing it, tell the president something that isn't the absolute truth in order to ingratiate yourself with the president. Spoiler alert, that's going on. So I actually said, fine. And I have done that every single time. And his advice was, if you do that, people will understand that you represent science, evidence-based information, and integrity, and you will get asked back by people who respect you. And if they don't ask you back, at least you have your own integrity. So I did that literally with every single president. And it worked very well, even when I had to tell, presidents that maybe we should do things a little bit differently. They either listened and said, that's a good idea. Or they said, I like you, Tony, but I can't do that right now. Yeah. And it worked out very well, with the one exception of when we had the clash of when the president was saying things that were not true. Yeah. And I was put into a position in front of cameras of having to publicly disagree with the president. Hydroxychloroquine does not work. Ivermectin does not work. Yeah. No, it's not going to disappear like magic. And that was very painful for me. The extremist theme is that I did it to underline the president. I have a great deal of respect for the office of the presidency of the United States. I didn't want to undermine anybody. But there was no way when a reporter asks you, is it going to disappear like magic? And the answer is no, it's not.
Yeah, no, and we all looked to you for that truth. Who was the funniest of the presidents?
The funniest, interestingly, was, real outright humor, jokester, was George W. Bush. He's the biggest jokester of them all. Right. But the subtle humors is Barack Obama.
Okay. Really interesting. You've brought us up to date, so it's time for us to visit some more modern times. One of the ways I frame that time, I remember this, and we have it on a slide, an article that was put together with one of those sliders from the New York Times, where you could estimate how long it would take for a vaccine for COVID. And if you left it at the default setting, you'll see, some of you might remember this, how long would it really take? Vaccine by November 2033. 2033. And you could move these sliders. Yeah. You could go do the trials at pandemic speed, and if you go to the next slide, you'll see you could get that down to maybe 2025. And then, if everything went completely well, sometime late, 2021, you brought together the forces that you'd been marshalling for decades to try to do that faster. On December the 20th, I think 2020, the same year that this began, the emergency use approval for the Pfizer vaccine was made. That's just the most remarkable feat of biomedical advance that we've ever experienced. And I think there are many people who should and can take responsibility and credit for that, but there is no one more central to that effort than you. Take us into that time.
One thing that is not fully appreciated and is the reason why I get so anxious when I see what's happening today of resources being pulled back from the NIH, of experienced investigators getting fired, of all the really unconscionable things that are going on right now at the CDC, at the NIH, is that started years before. Because if you look at the success, was three things, actually maybe four things. One was the science of the mRNA platform. The other was structure-based immunogen design to get the right stable spike protein. The other was a clinical trials network that was ready to hit the ground running. And the other was a phenomenal amount of risk-reducing investment in the development and the testing of drugs. So very quickly, I don't want to be too wordy about it. So let's go through that. The platform for mRNA, that research started 20 plus years ago. The defining paper by Drew Weissman was in 2004 in the journal Immunology, when he and Katie Carrico showed that when you modify the RNA molecule, it doesn't wind up, not being able to be used as a vaccine.
Yeah.
So that was years ago.
And you, by the way, were his postdoc mentor, right?
I claim credit for being his mentor for 8 years when he was a postdoc. I claim no credit for his Nobel Prize. None at all. Yeah. He did that independent of me. Right. The other thing was structure-based immunodesign. The people who were trying to develop an HIV vaccine were talking about the right conformation of the most immunogenic molecule for the HIV envelope. Forget about the spike protein. And really, really great scientists at NIH, at La Jolla, at Harvard, at Duke, here, people were working on it. And what they were doing was trying to figure out how you can stabilize the envelope in the right conformation, because it's kind of a floppy thing. So they came up with the right mutations to do that. The same people that did that, who were working on it for 25 years, were the same people who did it, Barney Graham and people like that who were at the NIH, to did the stabilized protein.
Yeah, Kizzy Corbett, you talk about in the book a lot.
So now you have 20 years plus, we started the HIV clinical trials network that includes people here in San Francisco, New York, all over, which is a network of clinical trialists who knew how to do a 20,000 person clinical trial. They were already established. So that's already there. So then you say to yourself, now we have a deadly outbreak, and it usually takes several years to get a vaccine. How can we get a vaccine very quickly? What you need is billions of dollars in what we call Operation Warp Speed, which was an interesting thing that we did, because when you develop a vaccine and you leave it all to the pharmaceutical company, they have to be careful of risks. So first of all, they don't manufacture anything at scale until they get absolute proof that it's going to get approved if it works, okay? So right away, you're talking years for that. You do a phase 1 study, and you usually don't prepare for a phase 2 or put everything into effect until you get results from the phase 1. We didn't do that. We put all money into phase 2, into phase 3 prep, so that we went seamlessly from phase 1 to phase 2 to phase 3. So we got the sequence on the 10th of January of 2020. 5 days later, we had the vaccine movement going. I called Barney Graham into my office on the day that they published the sequence, and I said, let's go for it. He said, we don't have enough money yet. I said, we're going to get the money. So we started we had the first phase 1 trial, 69 days, phase 2 trial, 198 days, phase 3 trial, 200 days. 11 months later, in a 30,000 person trial, we had the vaccine that was 93 to 95% effective. And all that took was investment ahead of time, and then billions of dollars that even if the vaccine failed, the only people that would have lost was the federal government, because the pharmaceutical companies put nothing into it. I mean, nothing, because they couldn't risk it. They didn't have the money to do it. So I think that can be done for any of a number of diseases if you want to put in the investment. But also, you can't forget that it was the year's worth of investment that antedated. The reason I'm saying that right now is that some of you are aware that the new mantra at the NIH is there's no such a thing as pandemic preparedness. In fact, there was an article written in Nature or Nature Medicine saying that we shouldn't prepare for a pandemic, is that all you need to do is to lead a healthy life, drink raw milk, exercise, and nobody's going to get sick. And that, I think, is really not a good approach given what's going on with Hunter and Ebola and everything else.
You've been a bastion against misinformation for decades, but you've lived in the absolute spotlight doing that. You've already described you're on camera, on TV, literally in the Oval Office, trying to speak truth to power. What do you think of all that? It's changed your life in ways that are very favorable. You have a very high favorability rating among many, but in other ways that are less favorable. Do you have any regrets about any of those moments?
If I had to do it over again, I mean, the idea of doing something that, can wind up saving people's lives, I mean, there's, I don't think there's any risk that you would avoid that, to do that. There really is a downside, because the amount of misinformation and disinformation is really rather treacherous in this country. I mean, social media is much more energetically driven by people who are spreading either mis or deliberate disinformation. And if you want to counter, which we have been trying to do, and I think we have to rethink our strategy, because, as I always say, it appears that people who are spreading mis and disinformation are so effective and energetic as it's almost as if they don't have a day job. So I assume that most everybody in this room has a day job. So you can't just spend all of your time, putting out counter information. We've got to figure out a way how to communicate better. And the thing that is the painful truth of our identities is that I will guarantee you that if you have a point you want to make about public health, somebody getting up, quoting a Nature paper with 25 supplemental figures and a big methodology will always lose out to an influencer who says, I tried this and it worked. And I'll guarantee you, data is not going to go against it. It's got to be better communication. Absolutely.
You still teach at Georgetown. You've edited a seminal textbook for 41 years. You've co-authored 1,300 citations. You've flown on Air Force One. You've worked with 7 presidents. You've received the National Medal of Science, the Presidential Medal of Freedom. You have 45, if I'm correct, honorary degrees. I didn't more?
64.
64 honorary degrees. You are, if I'm not mistaken, 85 years old. You don't need any of this. What gets you up in the morning?
My wife.
I can't think of a better place to end it. Family is such an important part of you. I get that from the book as well. You talk about your daughters and your wife in the most amazing way. I commend the book to you for sure. Please join me in thanking the legend, the man, Tony Fauci.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.